As my names have appeared up there, I want to take this opportunity to present what we are able or been able to do in the department, more so in the breast and endocrine unit. Phaechromocytoma, as you all know, it is a description which began with the Greeks, who said that there is this swelling which is dark colored, and because it is dark colored and it is involving given cells, and it is a tumor-like structure. That's why you see Phaeos, which is a dark colored structure, and staining to chrome, and cyto is for cells, and the oma refers to the swelling or a tumor. Much is known about this condition, and it began way back in 1886 by Felix Frankel, who described the patient who had similar condition and what we see and what has been described in these patients. And in 1912, Ludwig also went ahead to do a histological evaluation of these patients, or the pathological findings in this patient, and they still referred to it as a Phaechromocytoma. And in 1926, Cesar Roux from Switzerland, a Swiss, and Charles Horace Mayo, well known to most of you, these were the two people who started doing successful surgery in this area of the Phaechromocytoma. And in 1970, we have Grain and Tickler, who came up with this lineage of PC12 as cells closely related to the development of the a Phaechromocytoma. Much has been said about epidemiology by my predecessors who have presented here, but I have to mention a few things here as regards the prevalence of this condition. That it is noted mostly in the US, that's where we have more data about this, and the prevalence is ranging between 2 to 8 in a million people, and approximately 1,000 people have been reported yearly in the US, and mostly these are young and young adults. And when it occurs in a hereditary type, most of these people are slightly younger than the average. And as the first presenter said, it has been referred to as the tumor of the 10%. That is hereditary 10%, bilateral 10%, and so on, as he put it up there. The weight of this tumor is usually below 100 grams, but literature has it that has been found that we have lesions which have weighed up to 3 kilograms, but we have not come across this in our local setting. And the diameter has been ranging below 10 centimeters. And of course, these lesions, as you are all aware, they are to do with the sympathetic tissue, and it has an embryological correlation of these tissues. And we've not in the local setting, we realize that this tumor is usually associated with a 3% recurrence rate after surgical excision. It is a very vesicular lesion, and 10% of these, as we said, they are malignant, but if they are extraadrenal in origin, 30% of these lesions are malignant in that category. Of course, the literature has changed, and they are saying that in recent literature, 25% of these ones are familial, and they are not all of these patients will present with hypertension. About 14% of these patients will not have hypertension. And of course, this is a condition which consumes lots of resources. As we go on in our discussion, we realize that. And the presentation, usually it has been noted that most of the patients either present with headache or sweating, excessive in nature, that one will realize as he shakes a hand or he or she shakes a hand with somebody, will all be wetty. And we've had a number of patients in that category. And we have increased heart rates in these patients. Of course, the hypertension, as it has already been mentioned, is arterial in nature most of the time. And the other factors or symptoms present in these patients is frank pain and elevated glucose levels. A number of investigations are possible. But we realize that in most centers, including ours, we are not able to do blood tests to get the free metanephrines. So what is usually used, and in most centers which practice this kind of surgery, they resort to urine tests. And though they are not very good, but they can still serve a purpose, as you had the figures mentioned earlier on. And in addition to that, we couple them with the CT scans. And this CT scan should not only include the abdomen. When we talk of the extra adrenal lesions, we refer to all the sympathetic chain from this, the base of the skull up almost to the what? The coccyx. So where there is a sympathetic chain, this CT scan or these other investigations should be utilized. Then histology, it has been mentioned that you'll be able to see at H and E nested. This is not R, it is nested cells, arrangement of cells according to Zerbarin. What have we seen at Mulago in our setting? The story began some time back. In actual fact, when I was reading this, I recall the first time I stepped here on this podium, I was an intern, and it was in the same year that we initiated this kind of procedure here. But now I'm aging, so you can judge. But the story didn't end then in 1998. It has continued up to date. And the last one, or the most recent, was done yesterday. And the patient, as my colleague has told you, is recovering as scheduled in ICU. And of course, we've realized that we have no tribe to pinpoint, but if we lump them together, we've realized that we've had most of the patients we've had here. We've had a total of 27 patients. 18 of these are Bantu of origin, 6 are Luos, and 3 are others. These others, most of them have come from, we can rest it at that. But these others are people from southern Sudan. We could not pinpoint and say this one is a Luo, this one is a Muntu, or whatever. And of course, the total numbers I've already said, there are 27 so far, of which 11 are female and 16 have been male. The treatment offered in most of these patients, 24 of them have received the surgical excision, and 3 have not received the surgery. 2 of these declined. One was a lady with the PET, and the other one had metastatic disease, which we could not really touch. And the one who is dead was not after surgery. This patient suffered but in the interest of time, let us enjoy what we can enjoy, but very fast continue with this presentation. So this one who died suffered a severe CVA, and before she was offered surgery, he was offered surgery, was a young boy of about, I think 13, around there, and he passed on while on the ward. The regional distribution, 17 of these patients have come from the central region, possibly because this is where I belong. And not that most of the patients here have this, but I would believe that. Then 4 from the west, 3 from the east, and the north had nil. not 4. Then the outcome, 18 of these patients after the treatment have been controlled well, and the 5 are on drugs. The follow-up has been quite good. 18 have been followed, are still being followed up, and 5 of them have been lost to follow-up. The recurrence rate, we've had only 1 recurrence in one a boy of about, we started with this boy at the age of 7. Then after 3 years, he came back with similar symptoms. We operated on him. Then a year ago, he came back. We operated on him. And of course, not in the same area. You know, as I told you, these lesions are following the sympathetic chain. The last operation he had a lesion around the bifurcation of the common iliac. And indeed, after the procedure, he improved. Then a few weeks, I think a week or so, the pressure shot up. Then we were thinking of exposing him to NMBIG. But I don't know whether it were your prayers. The patient stabilized and is not on drugs. So we've only had 1 patient who has suffered a recurrence, and the age range has been from 7 to 60 years. And the location of these lesions, 13 have been on the right adrenal, 9 in the left, 15 have been extra adrenal. And the presentation has taken almost a normal picture, as already mentioned here. 17 have had elevated blood pressure, 4 headache, 4 abdominal pain, and sweating in 2. Of course, the rest are like as you've seen up there. Of course, what we've realized that during this period of ours, from 1998 to 2015, we realized that the picture is not so different from what we see elsewhere. But unlike in other centers, the patients in our center here who have reported to us are slightly older. And the recurrence rate is slightly higher. The other one is about 2 hours, if you calculate, is 3%. And no specific regional or gender correlation has been observed. If you subject the data I showed you to statistics, you realize it is not statistically significant. And mostly, these are Bantu, but not from a specific tribe, as you are aware of the Bantu tribes in this country. And I would say that surgery is possible despite the resource deprivation in our setting. In conclusion, I would say Phaechromocytoma is a common diagnosis at Mulago, and surgical treatment provides acceptable and comparable results amidst resource scarcity. Thank you very much.